Welcome to my remaining part of the video session of deep vein thrombosis and pulmonary embolism. Now, regarding the treatment, fibrinolysis with tissue plasminogen activator, 100 milligram as continuous infusion over 2 hours. Reserved for massive PE with acute right ventricular failure and hemodynamic instability. Intracranial hemorrhage risk may be as high as 3%. In one study, fibrinolytics did not reduce the mortality or recurrent PV at 90 days. Pulmonary embolectomy, reserved for massive PE in which fibrinolysis is contraindicated or has failed for patients with hemodynamic or respiratory compromises requiring cardiopulmonary resuscitation. Inferior vena cava filter. Filters are reserved for patients who have contraindications for the anticoagulation or having recurrent PE despite adequate anticoagulation, and those undergoing pulmonary embolectomy. A recent analysis showed a significant reduction in 90-day mortality associated with IVC filters. Prophylaxis. The best treatment for VTE is prevention. Proper prophylaxis may decrease the perioperative VTE risk more than tenfold. The method of thromboprophylaxis proven to be clinically effective and relevant are low-dose anticoagulants and mechanical devices. All patients should be well hydrated and early mobilization after surgery is mandatory. Non-pharmacologic strategies like early ambulation should be encouraged. Mechanical compression devices should be initiated prior to induction of the anesthesia and continued intraoperatively and then into postoperative period, and have to be worn at least 18 to 20 hours a day to be effective. IVC filters may be offered to patients who have contraindication to pharmacological prophylaxis. Now, pharmacological strategies based on the 2008 guidelines of American College of Cardiology. Prophylaxis is recommended by both level of procedural thromboembolic risk and individual patient risk. In general, the prophylaxis should be initiated 8 to 24 hours postoperatively when either the unfractionated heparin or low molecular weight heparins, low dose unfractionated heparin administered at a dose of 5,000 units subcutaneously every 8 to 12 hours reduces the risk of developing a DVT by approximately 60%, with a similar reduction in PE-associated mortality. There is, however, a marginal increase in the risk of hemorrhage, particularly in the patients undergoing surgery. Low molecular weight heparins are as effective, if not slightly more effective, when compared with low-dose unfractionated heparin, with fewer side effects, and usually require only daily dosing. Up to 28 days of VTE prophylaxis is recommended in selected high-risk general or gynecological surgical patients, and extended prophylaxis is indicated after major orthopedic procedures. Low molecular weight heparin is preferable to warfarin, and aspirin alone is not recommended in any patient population. Thromboprophylactic recommendations. Low risk. No thromboprophylaxis is recommended. Moderate risk. An effective form of thromboprophylaxis is recommended. This should be either in the form of an effective low-dose anticoagulant or an effective mechanical method. The thromboprophylaxis should be ideally started before the risk commences and should continue as long as the risk persists. And the high risk, an effective form of thromboprophylaxis is mandatory, and consideration should be given to using a combination of low-dose anticoagulants and mechanical devices. Continuation of thromboprophylaxis beyond the period of hospitalization should be considered. Now, summary of deep vein thrombosis. Prevalence. The estimated annual incidence of the estimated annual incidence of VTE is about 117 per 1 lakh and up to 900 per 1 lakh by the age of 85 years. Now, risk factors. Surgical patient, especially elderly, and patients undergoing orthopedic procedures are at a higher risk of VTE. Causes. Causes of venous thrombosis can be classified as inherited or acquired disorders. Pathophysiology. When hypercapnia becomes evident, massive PE should be suspected. Hypoxia is more often seen in pulmonary embolism. Diagnosis. For DBD, Doppler ultrasonography is most recommended, commonly used, while the contrast venography is considered the gold standard. For PE, CT scan and pulmonary angiography are the gold standard tests to evaluate the suspected PE and diagnostic PE respectively. Treatment for DBT should include the supportive care and anticoagulants. Treatment of PE should include anticoagulation, fibrinolysis, pulmonary embolectomy, and IVC filters. Now, what is the prophylaxis? The best treatment for VT is prevention. The method of thromboprophylaxis proven to be clinically effective and relevant are low-dose anticoagulants and mechanical devices. Here we come to the end of my lecture series, and next day I will come up with a new topic. Thank you.